I'm Leighton Koo with the Department of Health Policy and Management. It's my pleasure to welcome you to this afternoon's session, part of our continuing series on health policy experts talking about key topics about health reform during this changing time. Today it's my pleasure to introduce Professor Jeff Levy. His topic of his talk, as you can see on the slide in front of us, will be public and population health in an evolving health system. Let me give you a little background to Professor Levy before I start. Jeff just recently returned to George Washington University after a 10-year stint as the executive director of the Trust for America's Health, a leading public health advocacy and analysis organizations. Actually, during that whole time, he was still with GW. In fact, he began with George Washington University about 20 years ago. This is probably your 20-year anniversary now. Started in 1997. But he has had in addition to being a wonderful teacher, much beloved here, he has had a luminous background. He was chairing, I don't know if you still are chairing, the White House Advisory Group on Prevention, Health Promotion, and Integrated Public Health. I suspect that advisory group might be defunct by now. But at an earlier time in the Clinton administration, he was deputy director of the White House Office of AIDS. He is also a GW alum, got his PhD from GW, though not from the public health school. So I like to think of Jeff as one of our leading strategists, chief strategists with respect to advancing public health. I regret to say this was at a time when being chief strategist was sort of a good concept as opposed to a somewhat sinister concept. He's not a sinister person at all, though in the right light, maybe. But anyway, so this is today's talk. About a month ago, Sarah Rosenbaum gave a wonderful talk on some of the basic issues regarding health reform, and particularly some of the basic conceptual and legal issues that are going on. That is, if you are interested and available on YouTube, you can go to look for GWSPH and then click on videos under that heading, and then you'll see that Sarah's talk is still there. And in fact, this talk will also be recorded as well. In about a month from now, in March, I'll be giving a talk about the future of Medicaid and the health safety net. In early April, the School of Public Health will be convening a symposium on this topic. This is all evolving because, of course, we don't exactly know what's happening in Congress yet, as we'll all follow and learn as we go along. But with that being said, Jeff Levy.
Thank you, Professor Koo. It's always unclear from moment to moment what we are strategizing about, but this is, not having checked my Twitter feed in at least 5 minutes, this is the current state of the action with regard to public health, and a very volatile environment, to say the least. I would observe that despite predictions, say on November 9th, that by now we would have seen the repeal of the Affordable Care Act with or without a replacement, that train seems to be moving at a much slower pace. For those of us who watch public health, and the core of public health is so much dependent on annual appropriations, there is a tremendous vulnerability in the appropriations process that could see some very quick action, much quicker probably than with the ACA. And as insurance is taken away, people are aware of what is being lost. As public health funding is diminished, it takes time to realize what is missing until the next crisis. So with that really depressing overview, I want to step back a little bit and observe and sort of and give you a sense of what I'm going to try to cover, and I want to leave as much time as possible for discussion and questions. But really, this is very much a glass half full conversation. As we see greater attention being paid to population health approaches, or what I will, as you will discover, call accountable health approaches in the healthcare delivery system, that really begins to move our health system from just being a healthcare system to a health promoting system. That this, while incentivized and driven to some degree by the Affordable Care Act, is also happening independent of the Affordable Care Act because of the move toward more accountability, toward value-based purchasing. And if we are going to succeed in this very bipartisan concept of value-based purchasing, it's going to be important to have both partnerships with public health and have a very broad conception of what creates health, including addressing social determinants of health. That said, most of my talk is going to be about what surrounds the healthcare delivery system in creating healthy communities and a healthy population, but I cannot state strongly enough from a public health perspective that insurance matters. We sometimes forget that in public health because we're worrying about the general health of the population. But in fact, insurance matters because a lot of public health interventions are delivered one person at a time, and a lot of public health interventions do have a base in the clinic. Whether it is preventive benefits that were made much more robust and much more accessible by the Affordable Care Act, or whether it is there are incredibly important issues around what networks look like and what coverage really looks like, so that preventive services can be built. Those changes in the ACA have not just been profound for individuals, they have been profound for public health departments as well. Because public health departments, one of the essential functions of public health is assurance of access to appropriate preventive services. As the insurance system has taken on more of that responsibility, public health departments have been able to move away from direct clinical service delivery to thinking about policy systems and environmental change. With that shift is a shift in focus, a shift in capacity. If insurance goes away, that will become a real challenge for public health. So in fact, this is from a paper by Karen DeSalvo and John Auerbach, who describe the concept of public health 3.0. That in the early days, there are various ways that you can look at this. Public health 1.0 was very much focused on infectious disease control and the rudimentary approaches to public health. Public health 2.0 really began to think about more expansively about a role of public health, particularly around chronic disease prevention. And in Public Health 3.0, we're really talking about the collaborations and the partnerships that allow us to lead for public health, in Karen DeSalvo's term, being the chief health strategist for a community, for the nation, can start addressing and catalyzing addressing improvement in the social determinants of health. All of these are built on the changes in the insurance and the healthcare delivery system. If those changes go away, then there's the danger of public health having to revert back to Public Health 2.0 or Public Health 1.0, depending on how far back we go, without having retained the capacity to do some of those services. So population health is certainly the new buzzword. Everyone says they do population health. Healthcare systems say they do population health. Public health says they do population health. And everyone sort of defines population health a little bit differently. David Kindig, who is probably the philosopher of population health, has defined it as the health outcomes of a group of individuals, including the distribution of such outcomes within the group. So it can be geographic, it can be population specific, but the bottom line is that this is thinking much more broadly than one person at a time. And that it is not just about the overall health of a population, but the distribution of health. In other words, issues of equity. Then the question really becomes, who delivers population health? And I would argue that, and there's a lot of argument about who is doing true population health. when a healthcare system that says they're delivering population health, they're probably thinking about their patients. When public health thinks about population health, they're thinking about everybody. And so public health thinks they're pure, and therefore, since they think about everyone, that makes them better. It actually doesn't matter, because to achieve population health outcomes, whether you define your population as the beneficiaries in a Medicaid program, or the patients who come to George Washington University Hospital, or a geographic community, or a minority community whose health you may be concerned about, it doesn't really matter, because to achieve population health in our current understanding of what really does improve outcomes, it requires partnerships. It requires working across sectors. It requires paying attention to equity issues, and it certainly requires paying attention to social determinants. Now, I put of health in brackets because when we're working with other sectors, education may be a social determinant of health to us, but in the education sector, health is a social determinant of education. And in fact, to create viable partnerships, we really need to be thinking about how we work across those sectors and define population health in a way that is meaningful to all of those sectors. So everyone can be doing population health, whether it's a hospital partnering with a community-based organization that provides community health workers to help them stay healthy and not get readmitted within 30 days because CMS, through their value-based purchasing, will ding them otherwise, or whether it's a health department sitting at a table with the education sector and the housing sector and others to really address some of the upstream social determinants of health. A lot of the emphasis in the public health world around population health is focused on policy systems and environmental change. So that's our new mantra, and it's true. You can achieve a lot and have a tremendous impact on a lot of people if you make policy changes. But the truth of the matter is, as we think about social determinants of health, we also have to think about direct service delivery. So when you're thinking about addressing the health-related social needs of an individual, so we know that there needs to be an adequate supply of housing. That's a policy and systems change. But we still need the structures in place that link that individual who needs housing with the housing that may be available. So it is both. So this is probably a familiar slide to many of you. This is Elizabeth Bradley's work showing that, in fact, those countries that spend more on those social services, those things addressing what we would call the social determinants of health, tend to have better outcomes, and they are spending more on social services than on healthcare services. So you can see the United States sort of in the middle there. When you add healthcare spending and social services spending together, we are we're not that different from the rest of the world. It's just we spend a lot more on healthcare and a lot less on social services, and we have poorer outcomes. So a conclusion from this is that we have an imbalance here, and we might get a bigger return on investment if we spent more on social services. And I agree with that, but the care that we need to take in looking at slides like this or data like this is that it's not like we can flip that switch and suddenly reverse the ratio. We have a legacy of medical problems that have been created because we haven't addressed those social determinants, and we will not see those savings immediately if we ramp up our investments in social determinants. So it's in social services. So it's much more complicated than just flipping that bar graph. So I've mentioned a couple times actually thinking less about population health and thinking about accountable health. So we're in this world that thinks more and more about value-based purchasing and holding people accountable for outcomes. We all believe in that. And the concept of accountable health is, to some degree, a subset of population health, but it avoids some of the arguments around definitions. Accountable health approaches, and there are many approaches to accountable health, as I'll describe in a moment, integrate in varying degrees the health and prevention and public health, the healthcare and social needs of individuals and communities in order to improve health outcomes, reduce costs, and resolve upstream factors that affect health. So it takes the healthcare system, it takes public health and prevention, and it takes social determinants, and together says, how can we hold all of those players together accountable for improving the health of a community while staying true, I should add, to their core missions. So we can't be turning housing agencies into health agencies, but we need to find ways to have housing agencies understand, or organizations understand, that they are contributing to health and to adapt their work so that they do most effectively advance health outcomes. So value-based purchasing is really driving this move toward accountable health. You know, as health systems and others become held accountable in a financial way for improved health outcome, for rewarding outcomes over volume, it becomes more and more important to mobilize the necessary forces, so to speak, or activities or programs or policies that address everything that can affect health and can result in a reduction in demand for care. So I would distinguish accountable health from accountable care by saying that accountable care holds providers responsible for better management of clinical conditions. And you do have to have a link with the community and with community-based services and addressing some social determinants of health to better manage those clinical conditions. Accountable health creates a shared responsibility across all sectors for the health of a community or a patient population. Now, these are relatively new concepts. There are lots of experiments happening on both the accountable care side and the accountable health side. Accountable care is not just for Medicare anymore. There are 10 states that now have Medicaid accountable care organizations, with 6 in the planning stages. And there are 13 states that have created what are being called accountable communities for health. Some people call them accountable communities for health, some people call them accountable health communities, but some form of an accountable health experiment. So this is very much an experiment. It's being tested. The financing mechanisms vary. We don't know which ones work best. The sustainability of these experiments is very much in question, but this is very much a direction that the creative people in trying to improve health outcomes tend to be moving. So the ACA has made a huge difference in moving us toward and creating the building blocks for this notion of accountable health or better addressing population health. The first is the creation of the National Prevention Council and their issuance of a national prevention strategy, and I have chaired, I don't know whether it's quite yet the past tense, the advisory group on prevention, health promotion, and integrative and public health. And I won't go into detail on this, though many of you have heard me speak at length on this, except to say that while obviously this is not the centerpiece of the ACA, it actually the National Prevention Council set a table within the federal government where 14 federal agencies and offices were called together and said, prevention and health promotion is now part of your mission. And together they developed this national prevention strategy where they talked about creating healthy and safe community environments, which didn't just mean clean air and clean water, but understanding that if you didn't have safe streets, people couldn't be outside exercising. In talking about elimination of health disparities, it wasn't just what happened in the clinical setting, but also talked about the social determinants of health, and therefore how everyone has a role to play. And I could go on about that, but I think the bottom line here is it was a recognition on the part of the federal government and an integration into the work of each of these federal agencies with varying degrees of success, the notion that health is part of their work. Department of Housing and Urban Development was probably the strongest in that regard. They actually elevated health to their mission statement, but the Department of Defense has also done amazing work in integrating truly social determinants and community and policy and systems change in the communities that they control like bases, to really think much more broadly about what affects health outcomes. Oops, I need to go this way. Obviously, I mentioned earlier the importance of the coverage of clinical preventive services, how that has freed up health departments, how that has freed up resources, I think has been incredibly important. The investment in community prevention also cannot be underestimated. So we have moved from a concept of saying in public health to improve health promotion is brochures and health fairs and educating people about what it means to be healthy, to really thinking about the community environment, how we create a safer community for exercise, how we make healthier food more accessible, how we start looking at the policies like smoke-free air laws that can have a dramatic effect on broader populations. And over the course of the last 8 years, there's been a tremendous investment in creating that kind of prevention capacity at the local level that requires not a health department issuing regulations necessarily, but creating the coalitions and setting the table of the various sectors who need to come together to make these changes. So starting with the Recovery Act, with the Communities Putting Prevention to Work program, and then funded through ACA mechanisms, there's been close to $2 billion that has gone out to communities and states across the country to build that kind of prevention capacity, of setting tables. Now, the truth of the matter is that Congress has a limit, well, this is going to come as a surprise. Congress has a limited attention span and can't stick to programs for any length of time. Communities Putting Prevention to Work was part of the Recovery Act, so that was a time-limited intervention. Community transformation grants were supposed to be 5 years. Congress decided after 3 years, well, we don't really like that approach as much as we thought, even though they had no outcomes yet because they hadn't given them a chance to have outcomes, and they switched to partnerships to improve community health. So a lot of pulling and starting and stopping, but what's consistent here is providing support to communities to set a broader table. The capacity and the experience of public health agencies as conveners of multi-sector collaborations has been really important in setting the table for a role in this accountable health movement. The Prevention and Public Health Fund has been an incredibly important part of the ACA for public health. It is the first mandatory funding stream that public health has had. So this is now $1 billion a year that comes available every October 1. It was meant to be used for new initiatives. It's actually been a balance of new initiatives and protecting some core functions of public health, like lab capacity, and actually some of the immunization programs during a time of budget cuts and sequester. But that fund has been, without that fund, the CDC budget would be 12% smaller, which means that state and local health departments would have 12% less to work with. So that's been incredibly important and has been constantly at risk. It has been repealed dozens of times, at least by the House. It never became law. And is probably certainly one of the vulnerable targets in a repeal and replace environment. The community benefit rules for hospitals certainly could be a topic of an entire discussion. The requirement for nonprofit hospitals to invest in their communities. There are various elements to that, and our colleagues here in the department, Sarah Rosenbaum and Maureen Burns, have published about this. But for public health, what's important is the requirement for doing a community health needs assessment, and to do that in collaboration with public health departments. And so in creative communities, there's been an opportunity not just for collaboration, but for leadership by public health agencies in bringing the nonprofit hospitals together to do a common community health needs assessment. And again, where there are creative communities and where there is creative leadership and a willingness to play this chief health strategist role in a community, health departments have also been working with hospitals on how they implement their investments based on that needs assessment plan. The ACA has also made a difference in terms of the health workforce. The ACA supported primary care expansion, over 16,000 new providers. That was money, the money for those programs actually came from the Prevention and Public Health Fund. Not the original purpose of the Prevention Fund, but an important investment nonetheless. And you can see a number of other examples from teaching health centers, but I think and interprofessional practice and education grants, but what I think is also important to take into account is that through these changes in the ACA, we are seeing a much more inclusive workforce that includes community health workers, community EMS as part of health teams, and that means, and we have begun to see Medicaid reimbursement of non-licensed professionals, like community health workers, who are providing preventive services. That provides an opportunity to have a much broader sense of who does health and who contributes to health and to build community capacity. The innovation across the health care system and the healthcare financing system has also played a very important role in beginning to embrace population health. CMS has developed a population health framework that describes CMS's role in this regard. They have worked to within the limits of what CMS can legally do, because remember, they have to think about what is the impact on beneficiaries as opposed to an entire geographic community. Within those legal constraints, they've really been much more flexible about thinking about public health partnerships, about thinking about community level interventions. Some of the drivers of innovation include the Medicaid expansion, which means needing to address the needs of a different population. Many of the solutions to those needs can be found in the community. States have been using Medicaid waivers, as I mentioned earlier. 13 states have used either the state innovation model grants or waivers to create something that looks like accountable health communities or accountable communities for health. I mentioned the use of non-licensed providers in prevention services. And in fact, Medicaid managed care is already addressing a lot of social determinants of health under the radar. So managed care plans have a lot of flexibility to think about addressing health-related social needs. They've been doing it under the radar because they haven't quite sure whether CMS, if they looked under the hood, would say, ooh, that's really okay. But as CMS has embraced more of this population health framework and has become more flexible, we're learning about more and more managed care plans that have done innovative things with schools, have done innovative things around housing, have done innovative things around financial literacy, and on and on and on. Within the Center for Medicare and Medicaid Innovation, obviously the state innovation model grants have promoted the accountable communities for health. The diabetes prevention program and its certification now as a Medicare benefit is a community-based service that has been shown to be more effective in preventing progression to diabetes than clinically based approaches. And playing catch-up in a sense, CMMI has put out, and we are still waiting with fingers crossed for the awards to be made, for an Accountable Health Communities demonstration, $157 million that would go across the country to look at various approaches to addressing health-related social needs, but at the core is this Accountable Health Community model. And this would provide a real opportunity with a substantial investment to build the capacity in communities and really evaluate the impact of this approach on health outcomes and on costs. But overarching all of this is this increased drive toward value-based purchasing. That is not just ACA-driven, but it is market-driven, and it has very broad bipartisan support. With this growing evidence that if you address health-related social needs, you will improve outcome and value, and it's interesting to hear as the governors start talking about what might happen to Medicaid, many of them are saying, we want to preserve or enhance our ability to address these health-related social needs. So even in an environment where governors may say we want more flexibility from the federal government, part of the flexibility they are looking for is the ability to address these health-related social needs. There are challenges in doing this because, as we know, both purchasers, whether it's private employers or the federal government or Medicaid agencies, all have relatively short time horizons and want to see a relatively rapid return on investment. Actually, they want to see not just a return on investment, they want to see actual savings. So you can get a quick fix, in a sense, by providing short-term housing. We know for very high-risk patients with high utilization of emergency departments, housing instability is probably the biggest driver of their high costs. And if we address that housing instability, we'll be able to reduce costs. But there's also a need to think about the long-term interventions that over a lifetime will dramatically reduce costs and improve outcomes. And yet we see some managed care plans doing that. One example is the good behavior game. There's the CCO in a community care organization in Oregon that is supporting the integration of the good behavior game in the schools. Good behavior game has been shown through NIDA research over a generation to dramatically reduce healthcare costs, reduce substance use, reduce interaction with the criminal justice system, improve employment, improve income, all of these social determinants of health. And what's wonderful about the good behavior game is you're not selling it to the